I'm Professor Fidelma Dunn and I'm a consultant endocrinologist at Galway University Hospital. I've been looking after ladies who have diabetes in pregnancy for 20 years, and with my colleagues have developed this web set of videos to provide education for you, the person with diabetes, so that you understand the importance of preparation for pregnancy, regular attendance during the pregnancy, and a follow-up visit post the delivery of your baby for ongoing care. Gestational diabetes is a form of diabetes that occurs during pregnancy, usually after 20 weeks of pregnancy. Like you, it is picked up by a glucose tolerance test, which you had between 24 and 28 weeks. Now, gestational diabetes occurs because your pancreas is not functioning at 100%. During normal pregnancy, your body requires that your pancreas increases its production of insulin by 2 to 3-fold. This will keep your sugars normal during pregnancy. However, in women with gestational diabetes, their pancreas is not working 100% effectively, and therefore they are not able to increase the production of insulin as is required by the pregnancy. As a result, the blood sugar tests rise. Now, there are some risks associated with gestational diabetes, both for the mother and for the baby. For the mother, you have an increased risk of developing blood pressure in the pregnancy. You have an increased risk of having your delivery by caesarean section. But many women have normal deliveries. For your baby may grow at an excessive rate and be born larger than would occur in a normal pregnancy at the time of delivery. Some babies have difficulty controlling their sugars after their delivery, and this may require a period of time in neonatal unit care. Long term, you, the mother, are at increased risk of developing diabetes in your lifetime. And your baby also is at increased risk, though this is small, of developing diabetes and obesity in their lifetime. Gestational diabetes is on the increase. In Ireland, the number of women affected is 12 in every 100 pregnancies. There are many factors associated with the rise in the rates of gestational diabetes, but primarily it is related to an increase in obesity rates, a reduction in exercise, an increase in a refined diet, and women are having their babies at an older age. Other contributing factors are infertility issues, the presence of polycystic ovarian syndrome, or previous episodes of gestational diabetes. Once you are diagnosed with gestational diabetes, you are generally transferred to a different clinic that has a multi-team approach where you will see an obstetrician, a diabetes nurse specialist, a dietitian, a diabetes physician, and a midwife, all of which will contribute to the control of your sugars for the duration of your pregnancy. About 70% of ladies will manage to keep their sugars normal by modifying their diet and attending a regular exercise program. In the other 30% of women, insulin is required to keep the blood sugars normal, but the insulin will only be for the remaining 12 weeks of your pregnancy. Once the pregnancy is complete, in the vast majority of people, the gestational diabetes goes away and you revert to whatever is normal for you.
Gestational diabetes. You've now been diagnosed with gestational diabetes following an oral glucose tolerance test, which involved having blood tests and drinking a sweet sugary drink. Now you have shown that you have an elevated blood glucose level in your pregnancy. After diagnosis, this time may be quite daunting, but don't worry. We'll offer you an extensive package which will give you information on diet, exercise, monitoring. We'll also supply you with lots of reading material which will help you through this time. We'll also supply you with monitoring equipment and you will be asked to test your blood sugars 7 times a day, and we will evaluate your progress. Most ladies will be managed successfully on just diet and exercise. After a period of trying diet and exercise to control your blood glucose levels, if this is not successful, we will help you administer insulin therapy. You will learn how to use your pen successfully and administer your insulin daily as required.
As part of your specialist care, you'll be given advice on regular activity and exercise. And the reason for this is we know that it lowers blood pressure, it helps control cholesterol, it helps your blood sugars, and many, many more important factors. To get the benefits, you'll be advised to do 150 minutes spread over the week of moderate intensity activity. So one example would be 30 minutes a day. It's important to start off gradually and build up slowly, picking gentle activities, things like walking, swimming. You can seek advice from specialist care. The most important thing is it's enjoyable, it fits into your daily routine. Irrespective of the type of diabetes, it's important to check your blood sugars before and after you exercise. And you may need a snack in order to help prevent low blood sugars. It's important if you're on an insulin pump that you think about checking your basal rate for exercise purposes as well. You'll be getting more advice on a one-to-one consultation to give you a personalised programme to help you get the most from your activity.
A diabetic should always follow a healthy, balanced diet, but this is especially important during pregnancy. Follow a healthy, balanced diet. Eat regular meals with a small portion of high-fibre carbohydrate food at each meal. Eat plenty of vegetables and limited fruit. Avoid added sugars in your diet. Breakfast needs to be small. A healthy diet contains a balance of foods to support baby's growth. The food pyramid is a good guide of how much of each food you need every day. Your dietitian can help you with meal plans that suit your own needs. There are 3 basic nutrients in food: carbohydrate, protein, and fat. Carbohydrates provide us with most of our energy. Carbohydrate foods turn into sugar or glucose after you eat them. It's important that these foods are eaten in small quantities throughout the day. Include a small portion of starchy carbohydrate at each meal. Choose high-fibre, whole-grain options. Protein is essential for your baby's development. Protein is found in meat, chicken, fish, eggs, peas, beans, lentils, tofu, nuts, and cheese, and will not turn to sugar when you eat them. Fats do not turn to sugar, but should be limited in your diet. One special fat, omega-3, should be increased in your diet. The best source are oily fish, such as salmon, trout, mackerel, sardines, kippers, and herring, and you should aim for 1 to 2 portions of oily fish per week. Vegetarian sources of omega-3s include soya, walnuts, and rapeseed oil. The following are types of carbohydrate foods: starches, milk and yogurt, fruit. Starches. A small portion of high-fibre carbohydrate should be eaten at every meal. Milk and yogurt are good sources of calcium. Choose sugar-free yogurts, diet or light, and limit your milk to no more than 3 glasses of 200 ml each day. Eat plenty of vegetables and a limited amount of fruit. It's best to avoid fruit juices and smoothies. Avoid dried fruits such as raisins, sultanas, dates and apricots, and eat only 1 piece of fruit at a time. Avoid added sugars in your diet. Sugar and sugary foods like chocolate, sweets, cakes, honey, jam and fizzy drinks, and sugar and chocolate coated breakfast cereals. Avoid foods labelled diabetic or made with sugar alcohols like sorbitol, malitol, xylitol. They're often high in fat and can cause wind bloating and diarrhea if you eat a lot of them. Some medicines, like medicines for heartburn and constipation, contain sugar. Make sure all the medications you're taking are sugar-free. Speak with your doctor or pharmacist about sugar-free options that are safe in pregnancy. Include a small breakfast each day. Blood sugars tend to be higher in the morning. In summary, to keep your blood sugar levels under control during pregnancy, Eat 3 meals and some snacks spaced evenly over the day. Limit portions of carbohydrates. Avoid added sugars and sugary foods. Include a small portion of starchy carbohydrate at each meal. Limit fatty or fried foods and takeaways. Do not skip meals and drink plenty of water and other sugar-free drinks throughout the day.
As part of your package, we will highlight some issues which may arise throughout your pregnancy, which will have to be dealt with promptly and correctly. If you are using insulin therapy for your gestational diabetes, there will be other considerations we'll pay attention to. Hypoglycemia, an event which often occurs in the first trimester, where we're keeping very tight control on your sugars. We will have prepared you and your partner and your family to detect, treat and prevent this occurring.
Hypoglycemia. Hypoglycemia, or hypo, is the term used if your blood glucose levels go too low, below 3.5. This can happen for a number of reasons, such as delayed or missed meals, not eating enough, vomiting, too much exercise at one time, inaccurate dosing of insulin, alcohol, hot weather, breastfeeding. You'll learn how to recognise your own early warnings of a hypo, and these may include nervousness or anxiety, shakiness, sweating, tiredness, confusion or hunger. If you experience any of these symptoms, you should do a blood sugar test to check your level. If your level is below 3.5, you're having a hypo. To treat your hypo, take 15 grams of fast-acting carbohydrate that contains sugar, and this is provided by one of the following: 5 glucose tablets, 100 ml of Lucozade, 150 ml of pure fruit juice, not diet, or a sugary drink such as Coke. Follow this with a slower acting carbohydrate like fruit, bread, or breakfast cereal. Check your blood glucose levels again after 10 or 15 minutes. If you're still below 3.5, repeat the treatment and test again until your level comes up. Remember to always carry glucose tablets or some form of sugar with you. Severe hypoglycemia. If the episode progresses very quickly or the warning signs are ignored, you may not be able to administer your own treatment. You may have to rely on family or friends, which is why it's vital they understand what to do. The signs and symptoms of a severe hypo include poor concentration, slurred speech, glazed eyes, poor coordination. You may appear to be drunk, confusion, drowsiness, or a loss of consciousness. Immediate action must be taken. If you're conscious and it's safe to swallow, have some sugar. The liquid form is easiest. Or 15 grams of fast-acting carbohydrate, glucose sweets, sugary drink, fruit juice, and once you start feeling better, check your sugar. Again, follow this with a slower acting carbohydrate like fruit, bread, or breakfast cereal. Explain to your family and friends what to do if you pass out or become unconscious, which is the following: place you in the recovery position and inject you with glucagon. If glucagon is not available, call 999 immediately for medical help. Insulin should never be given to an unconscious patient. Always report a severe hypo to your nurse or doctor.
Hyperglycemia, ketoacidosis, a serious medical condition. This indicates that your body is lacking your essential insulin, which also creates a state of dehydration in your body. This condition, if untreated, allows your body to develop acidosis, which can be threatening to your unborn baby and also to the maternal health. This can be caused by nausea, vomiting, an untreated infection like a urinary infection, or omission of your insulin. In preparation for your pregnancy, we have given you the skills to help you cope with detecting and treating this type of condition. Preeclampsia, a medical condition which usually occurs in the last trimester of your pregnancy, associated with an elevated blood pressure and also the detection of protein in your urine. You may also have some swelling of your lower limbs and fluid retention. This condition warrants that you will have to have treatment, i.e. an early delivery of your unborn baby, or medical treatment in hospital requiring stabilisation of your blood pressure. Preterm labour. This term describes a labour which has occurred before the baby is fully developed. It may occur before 37 weeks gestation. In this instance, your baby may require specialist treatment in the special care baby unit. Polyhydramnios, an increase in the amniotic fluid, the fluid in which your baby floats. This can indicate poor glycemic control and often prompt a premature labour. But with the increasing of your insulin doses and better glycemic control, often this polyhydramnios can be reduced.
The vast majority of women with gestational diabetes will have a normal delivery at term. This would be regarded as week 37 to 40. If your diabetes has been treated with diet only, your midwife will check your sugars regularly during active labour and delivery to make sure that they are maintained between 4 and 7. Should your sugar go outside of this range, small doses of insulin may be administered to you during the labour process. On the other hand, if your diabetes has been treated with insulin, you will continue to monitor your sugars and take your insulin regularly as prescribed until you are in the active stages of labour. When you are in active labour, your midwife will put you on a drip of sugar and insulin. With the drip of sugar and insulin, the midwife will be able to regulate your body sugar to keep it between 4 and 7 during the active phases of labour. This is important to make sure that your baby's blood sugar is normal post-delivery. Should you require a caesarean section, this will normally be planned. The decision for caesarean section will be made on an individual basis by your obstetrician. This decision is made on the basis of your health and the health of your baby. If you require a caesarean section, once again, you continue to maintain your own blood sugars with your own monitoring and insulin doses as prescribed on the day prior to the delivery. On the morning of the delivery, your midwife will place you on a drip of sugar and insulin, regulating your blood sugars between 4 and 7 during the caesarean section period. This is important to maintain normal sugars in your baby. Post-delivery and following gestational diabetes, your blood sugars should return to normal. All insulin is discontinued post-delivery and you resume your normal diet and exercise pattern. We would, however, encourage you to breastfeed your baby. This is important in reducing your risk of developing long-term diabetes, in keeping your sugars normal, in helping you to reduce your body weight and return to your pre-pregnancy weight. It is also beneficial to your baby both in the short term and for their long-term health. It is very important to come back for a postnatal visit. At this visit, we will repeat your glucose tolerance test. This is important to establish whether the diabetes has gone away or whether you remain with a sugar-related problem. Overall, in the first year following the delivery of babies to mothers with gestational diabetes, about 18% of women continue to have a sugar problem, and the remainder of those ladies return to normal. However, as time progresses, the number of women who develop diabetes increases, and overall your lifetime risk of developing diabetes is 7 times higher than women who did not have gestational diabetes. The postnatal visit is very important, therefore, to establish your sugar status at this time. Again, we will reinforce the principles of diet, exercise and weight management, as we know all of these things will reduce your progression rate to diabetes long term. We will also mention to you the importance of pre-pregnancy care prior to your next pregnancy. This is important to ensure that you have a sugar check with your GP prior to the next pregnancy to ensure diabetes has not developed.
When I was first diagnosed with the gestational diabetes on my first pregnancy, I was worried about it and its effect on me and its effect primarily on the baby. That was the overriding concern. But in the clinic they explained it thoroughly, and that basically they would be monitoring very closely the development of the baby between then and me having her. They started me out with the diets and encouraged exercise. And so I took the diet on board and I followed it, and I was exercising with walking, and I included swimming. And the result on my first pregnancy was that I managed without insulin and had a healthy baby girl without any complications whatsoever. Before or after, it was all good, and came to the 12-week checkup, and they were happy with me. And again, they advised that if I was considering another pregnancy to be in touch with them and for monitoring and to look after my health and my diet and the exercise prior to any subsequent pregnancies. With pregnancies 2 and 3, certainly with the second one, I tried to my level best to keep up with the diet and the exercise. I kind of knew, well, if I don't, I could end up with the gestational diabetes again. But life was a bit busier with a toddler in the house and being pregnant for a second time. And I did again end up being diagnosed with the gestational diabetes. The difference this time was that I didn't actually get to manage it with the diet as well as I had hoped, and I was put on insulin. The insulin is administered via a pen that you just turn and click, and the team showed me how to use it. And I was worried, scared, especially, insulin, I just thought it was a bit kind of, for me, for the baby. But obviously it's all for a good reason, and I, had no problem administering insulin to myself. It seems scary, but it's not. It feels quite normal in the end. And that also helped maintain the growth of the baby until I had yet another healthy baby. And it was similar to the first. I was back from my 12-week checkup, and again I was okay afterwards. I passed the glucose tolerance test, and they just spoke to me about my weight and maintaining a healthy lifestyle, and again the importance, especially now that I'd had a baby and I'd been on insulin during the pregnancy, of being in touch with them for any subsequent pregnancies. And I was monitored a lot earlier and sooner around my 3rd pregnancy, and unfortunately I ended up on the insulin a bit sooner with her, and I feel that was because I wasn't as diligent with my diet and exercise at the outset. With 2 young children working and being pregnant with a 3rd, it was kind of hard to find the time. But as I progressed, I got better, because you have to look after yourself, and you have to look after the health of your baby, and this is encouraged by the team in the hospital, and they give you every help, and they're always at the end of the phone as well. So if you have any questions about anything, they are very, very helpful. And again, I ended up with the insulin and the pen, and I had no problems really this time. Just a bit of a refresher, and it was like old hat to me. And the 12-week checkup, which I've just recently had, and again I don't have thankfully any diabetes, so it's back to normal for me, but to watch out for my diet and my exercise and to look after my health, because the result of gestational diabetes in the long run is that there's a 7% chance of it developing into type 2 diabetes later on if I don't.
My name is Tracy Dunbar, and I was diagnosed at 27 weeks with gestational diabetes through the screening test in the hospital. Initially, to be honest, I was very shocked, because I guess I didn't see myself as the normal diabetic. I'm fit, I'm healthy, I diet, I look after myself, and it just came as a little bit of a shock. But at the same time, I was a little bit relieved, because I was very sick. I was very dizzy, very nauseous, my heart was beating fast. I felt very, very, very unwell. So after I chatted with the team at the hospital, I realised this is good. I can get on the medication. I started insulin straight away. We devised a very healthy eating plan, and we talked about the very importance of looking after myself, monitoring my insulin levels throughout the day, which I did before and after every meal, eating properly, eating regularly throughout the day to make sure my levels didn't fall or rise. And it actually all went really well. We kept in communication with the hospital. I went to see them every 2 weeks, and in between that we spoke on the phone. I had super care, and at 39 weeks I delivered a very healthy baby girl. And after 12 weeks, after that I went back, and my levels were okay, sort of underlying, but I was okay. And we checked my levels every 6 months, and we were okay. And after I got pregnant the second time round, again I was diagnosed with gestational diabetes. I had a handle of it at this stage, so I was able to work with the team again regarding diet and exercise and checking my levels and just making sure that we were okay. And I was in great communications with the hospital. They really looked after me. I gave birth to a very healthy baby girl again. But this time round, after the 12-week checkup, my levels didn't go back to normal, so I am a diabetic now, and I look after it with medication that I take in the morning and evening.